All right, good afternoon, everyone. I get a chance to tell you about a very special place that's very dear to my heart. So, my name is Dave Teng. I'm actually pediatric trained in my residency at Cohen Children's, did my fellowship in pediatric emergency medicine at Columbia, and I'm currently program director for the Pediatric Emergency Medicine Fellowship at Cohen's and director of point of care ultrasound there as well. So I get to have fun in two different places. So today's kind of experience I get to tell you about is about my experience in Haiti. So today we're going to kind of touch upon the challenges of performing point-of-care ultrasound in a resource-limited environment, specifically what I do in St. Damon's Hospital in Haiti, and describe some point-of-care experiences and kind of go through a few cases for you on where we find, at least in my environment, point-of-care ultrasound really made a difference. Okay. So some of the challenges, and I'm talking to the people here who are drinking the Kool-Aid, so you guys have been in resource-limited environment. I'm hoping most of you have touched an ultrasound, and not only that, using it actively in your patient care, hopefully in the resource-limited environment. How many have been to Haiti? Great, merci. So Haiti is probably one of the poorest countries in the Western Hemisphere, and you guys should know that. For kids, because of the really poor sanitation and poor availability of vaccines, a child born has a 15 times more probability of dying from a preventable disease, diarrhea, pneumonia. 10% of kids do not make it to their 5th birthday. Okay, so these are the challenges. However, I get to work in the St. Damien's Pediatric Hospital, which is located about 20 minutes northeast of Port-au-Prince. It's in the small town of Tabar. If you've ever get a chance to go, it's a really wonderful place. One of the only freestanding children's hospitals in Haiti. So specifically for today, where does point-of-care ultrasound come in, right? So the challenges that my esteemed colleagues here have already brought up, we get to do a lot of interventions, bring a lot of the things that we've learned here in your training down there. But then what, right? So pediatrics is unfortunately not immune to those same restraints. I'm able to use point-of-care ultrasound, but then what? My pediatric surgeon for the hospital comes every 2 weeks. We'd be lucky if there's a cardiothoracic surgeon somewhere on the island. So a lot of the surgical emergencies that we routinely come and aren't surgical emergencies anymore in my pediatric emergency room is life and death down there. The reason why I put this picture up, this is their portable x-ray. Now, my colleagues have mentioned the use of x-ray in labs and stuff like that. In this hospital, before you can get an x-ray, you have to come up with $15. And you would imagine, well, I just spent $15 on a sandwich and a cup of coffee, right? So $15, that's an immense amount for that. So not only do you have to go down to the cashier, pay for the x-ray. Once the x-ray is done, it takes about 2 days for you to find. So then I'm hoping your brain's already starting to work. So what's the utility? Okay, and this is where your point-of-care ultrasound comes in. Right? So not only are there preventable diseases that the kids are dying from, there's a lot of diagnostic enigma that happens because your adjunct x-rays labs aren't always readily available, right? So there is a pediatric residency. I started going down in 2016. Obviously that was waylaid a little bit by the pandemic, but we started teaching the residents and staff point-of-care ultrasound, specifically in lung, because there's no pneumococcal vaccine. They saw a ton of pneumonias. Okay, and we'll give you some examples later on in the talk. Some of the ergonomic or environmental challenges that we see, right? So that's me and my fellow Danny Paulin from Akron Children's. This is so everything is outside, right? So I'm sure you've heard talks about medical tourism and trying not to do the one and done. And so, this is their ultrasound machine. So we didn't go down and bring a whole lot of butterflies, a whole lot of machines, and then left. We made sure we taught them on their machine. So this way they were able to at least maintain it and get used to that machine. It was an old Philips, but guess what? That's all we had, so we made that work. But that's us pushing, going from different, so you can imagine, think of, listen, the emergency room is already a crazy environment. Could you imagine now outside? Is it gonna rain, right? That ramp is not flat, right? And so these wheels, like we were thinking of actually putting it on some tread wheels, so this way they were able to move quicker, right? But the idea is that those were our challenges to use point of care ultrasound to try to kind of get through, okay? So let's just go through a few cases here, all right? So we start with an 80-year-old girl with fever for 7 days, cough, congestion. He complains of right side abdominal pain, right? Since we're starting on the lung side, right? So they may or may not have the money for an x-ray. We have no idea, but she still has these complaints, okay? You know they don't have pneumococcal, and we're trying to see. So for anyone, any trainees out here, anyone, what do you guys see? Good, spine sign, excellent, right? So, Adam, what's going on? It's okay. All right, so spine sign, excellent, perfect. So the spine sign allows you to, normally you wouldn't see that, right? So normally a normal air-filled lung would block that part of the thorax. You would not be able to see those vertebra. The fact that you see it, you can tell that there's either some fluid or some consolidation, because now the ultrasound beam is kind of coming through, all right? So excellent, great pickup, all right? So now we're looking at here. So for us, you know, so what is pleural effusion gonna look like? You know, so like for us, you know, this allows us to say, okay, here's this kid, we have this. You may not even see all this on the x-ray, okay? So now it kind of makes that dilemma. Now for the emergency medicine people, or even for all you guys, you know, this is not anything that you're like, okay, pleural effusion, great, let's start antibiotics and go. For us, the question is, how bad is the effusion? I can't tell you how many kids, when I get down there, already have a chest tube, and the tube is not either in the right place, there's a loculated fluid, or it's just, you know, they, using clinical, they'll listen to decreased breath sounds, think that's either pneumothorax or pneumonia, and move on. And it's just, this allows us to kind of at least see a little better. So there's your effusion with the spine sign, excellent. Normal, just for those that are not as savvy, which I don't think anyone in this room is, but the idea is that there is no spine sign here, and you're able to at least, I don't know if I have a cursor on this, Adam, but anyway, so here you're able to then see at least your mirror imaging and not the spine sign. So this was a normal, and I just wanted, just from an ultrasound education point of view, just pointing out the two sides for effusion and then non-effusion, okay? But the idea is that allows you to say, let's see if I had a normal ultrasound. That will help you as well. You know, for us, bronchiolitis in even a resource-limited environment still is seen. So that's one example. The other example is a 4-year-old presents in emergency room respiratory distress. You know, he's been sick for a while with intermittent fevers. You know, so what are we seeing here? What did you say? Lung sliding, excellent. B lines, excellent, right? So remember, B lines show that there's some fluid at that septae, whether it be in that area. If we see this in all quadrants and the whole thing, what are we talking about? Pulmonary edema, excellent. So the idea is that, remember, the B line goes straight from the pleural line all the way down, as opposed to just a lung common tail artifact. But the idea is, you see this, there's got to be something going on. Okay, great. What are we seeing here? Give me a few things. Just yell it out. Go ahead. Good. Spine sign, I heard. What else? Consolidation, great. Good, like that. What else? You got one more. Hepatization, right, and then I heard pleural effusion somewhere, right? So the idea is that these are 4 entities. So loculated, excellent, right? So the fact that you're even seeing any of this tells you that there's definitely pathology in that thorax, right? But the idea is that even this is going to be a whiteout on that x-ray, but once you have a whiteout on the x-ray, you have no idea what that means. It could be fluid, it could be consolidation, it could be anything, right? So you actually see the lung, you know, whether, so hepatization is perfect. That was a great answer. There's a little trace pleural fluid, but not enough, I don't think, to commit the kid to a tube. and then spine side. Great, you guys picked it up. Okay, so remember, so that's your fluid, right, which we saw previously. Okay, but the idea is that now you have all these things that you just now whether or not this progresses to that, which is entirely could be. Remember, these kids they don't get any help, and sometimes it takes 4 or 5 days to actually get to the hospital. So that's where that changes, right? So the idea is that as we're kind of spanning through, you're then able to see. So correct on the lung abscess, consolidation, pleural effusion, all that stuff. So the last case we have is the brother comes in, again, as well, sick into the emergency room. He also has fevers in quite some time. This is very common, all right? So how do you differentiate between the two? What are we seeing here? Is it right? So the idea is that, so this is actually pleural fluid. I'm going to actually change this here. So that's what it looks like here. So what probe are we using in here? What do you think? Transvaginal. Excellent. Endocavitary. Why are we doing this? So at the time, our curvilinear probe was out. So we needed to see something broad. Okay, so this is using what you have in front of you to actually see. Remember, your endocavitary probe is actually a high-frequency probe, but you're able to see, right? Because you're 1, 2, 3, 4, 5. You're probably only 6 centimeters down, right? So use what you have into you. We've actually used the endocavitary probe to look to go through the fontanelle because it's a high-frequency probe. It's awkward, but it's what you got. Okay. These are just kind of cases to kind of bring home kind of what we're kind of seeing, at least on the clinical front. You know, so just from our experiences down there, you know, and I'm not preaching anything because you guys already know this, right? So the kids just have really a poor chance of living. But the idea is that with these cases, you can actually monitor and actually manage their interventions a lot more safely. Help the ped surgeons when they're around without them having to shell out a month's worth of money just to get an x-ray that may or may not even help you. I haven't even touched upon training and education piece, and that's a whole different ballgame. We can talk about that afterwards, and obviously the environmental. But the idea is that these were my challenges, and I would love to kind of hear what you guys have to say during our Q&A. But learn bubble CPAP. That was probably one of the coolest things I've learned in a while, because during bronchiolitis season for us in Haiti, we would literally string bubble CPAP across the wall, and you'd have babies up and down just on bubble CPAP, because we had 3 vents in the entire hospital, which is great, but we had no tubing, and that was the challenge. So just for you guys, know that before you go down to your respective places, what do they need? What, you know, it's not just here, this is what I have, it's really what they need, and emulate all the other messages that my colleague have given us. So thank you for giving me the time to tell you about a special place.